Right. So a very good evening, everyone. So in this particular section, I'll be discussing about the bone disorders. Mainly, it is the endocrine disorders, wherein I'll be discussing the hyperparathyroidism and as well as the hypoparathyroidism. And along with that, I'll also be discussing the recent trials and the new molecules which have come up and the new treatment options that have come up for the hyper and as well as the hypoparathyroidism. And I will also be discussing some of the multiple choice questions as well. All right. Okay. Yeah. Alina, good evening. So neurology, I'll just discuss with the team about the neurology, Dr. Alina, and then we will just get back to you soon on the neurology session as well. Okay. All right. So in this session, the first topic for the discussion in the bone disorders will be the hyperparathyroidism, right? So in case of the hyperparathyroidism, you need to know what are the etiologies for the hyperparathyroidism. So we have primary hyperparathyroidism where the problem is within the gland, then followed by that. Yeah, yes, good evening, Dr. Deepal. Right. And we have secondary hyperparathyroidism where the abnormality is mainly because of hypocalcemia and then ectopic causes for parathormone release. So if you see this primary hyperparathyroidism, where the problem is within the gland itself. And what is the most common cause for primary hyperparathyroidism? Most common cause for the primary hyperparathyroidism will be parathyroid adenoma, and that too solitary parathyroid adenoma. Right, solitary parathyroid adenoma. That is the most common cause for the primary hyperparathyroidism. So, and what are the causes? And what are the other causes for primary hyperparathyroidism? The other causes include parathyroid hyperplasia and as well as parathyroid carcinoma as well. Then we have secondary hyperparathyroidism. Right? Then we have secondary hyperparathyroidism. So secondary hyperparathyroidism, the etiologies include, they are the one which will mainly cause hypocalcemia. So what are the systemic conditions where you will have hypocalcemia? That is chronic renal failure, right? There will be hypocalcemia and that will trigger parathormone that will result in secondary hyperparathyroidism. Next is vitamin D deficiency. Next, malabsorption disorders, right? Or malabsorption syndromes. Then we have some drugs which will cause hypocalcemia. What are those drugs which will cause hypocalcemia? That is bisphosphonates, right? So bisphosphonates, right? So bisphosphonates, they are the drugs which will cause hypocalcemia. Actually, bisphosphonates are the treatment in case of primary hyperparathyroidism. But bisphosphonates, like in a normal person, if you are giving bisphosphonates, they will induce hypocalcemia and that will trigger parathormone release, that is secondary hyperparathyroidism. All right. Then we also have ectopic causes, right? We also have ectopic sources for the parathormone release. What are the ectopic sources for parathormone release? That includes the squamous cell carcinoma of the lung, right? That includes squamous cell carcinoma of the lung. And the other important etiology is the adenocarcinoma of the kidney. These are the ectopic causes for the hyperparathyroidism. So hyperparathyroidism, we have primary, then secondary, and then ectopic causes. So in the primary causes, the most common cause will be the solitary parathyroid adenoma. Then if you take the pathophysiology of the hyperparathyroidism, basically what will happen in patients with the hyperparathyroidism. So parathormone, it will increase the calcium and it will decrease the phosphate. How it will increase the calcium? It will increase the osteoclastic activity in the bone, right? And it will increase the calcium absorption across the kidney. And it will also indirectly increase the calcium absorption from the intestine by increasing the vitamin D synthesis. These are the ways by which parathormone will increase the calcium. Then hypophosphatemia. So what the parathormone will do? Parathormone will inhibit the phosphate reabsorption at the level of renal tubules. So when more and more parathormone is there, more and more phosphate is not reabsorbed, and that will result in the hypophosphatemia, right? And because of increase in calcium that is accumulated in the kidney in the form of stones, and thereby the individual will develop nephrolithiasis. And this excess parathormone will also stimulate the parietal cells, and that will result in the peptic ulcers. And this parathormone will also cross the blood-brain barrier, and parathormone will accumulate within the brain, and that will result in the mental changes, right? And then bone resorption, right? The basic physiology of parathormone is what? To increase the osteoclastic activity in the bone. So there will be bone resorption, and you will have then osteoporotic bone, right? Osteoporotic bone. Now, what do you understand by the word hypercalcemic parathyroid crisis? As such, this term or this entity, hypercalcemic parathyroid crisis, it is one of the rare entity, right? But here, these individuals, they'll have severe form, which is causing marked dehydration, and as well as the patient will go into a state of coma. So because of severe form of hyperparathyroidism, if the individual is going into a state of severe dehydration and coma, that is called hypercalcemic parathyroid crisis. Now, as such, if you take hyperparathyroidism, right, it is common in the age group of more than 60 years. And the peak incidence, it is around 3rd to 5th decade of life. And the etiology is just now, as I was discussing, primary, secondary, and then the ectopic causes for hyperparathyroidism. The parathyroid tumors, they constitute the primary causes for hyperparathyroidism. Then secondary causes for hyperparathyroidism, what are those? Secondary causes include chronic renal failure, vitamin D deficiency, malabsorption syndrome, bisphosphonates, and there are also certain drugs which will increase the vitamin D metabolism, like phenytoin. They increase the vitamin D metabolism, and thereby they will reduce the vitamin D deficiency, right? Or they will increase the vitamin D deficiency. Next is MEN syndromes, right? So which are those MEN syndromes which are associated with this parathyroid adenomas? One is your MEN1. MEN1, it is associated with parathyroid adenoma. Not only MEN1, even MEN2A, even MEN2A, that is MEN2A, which is also called Sippel syndrome, that is also associated with parathyroid tumors. So MEN1 and as well as MEN2A, you will have this parathyroid tumors. Done? Now, so most common cause, what did we discuss? Solitary parathyroid adenoma. So they constitute nearly around 80% causes for the hyperparathyroidism, and that too primary hyperparathyroidism. Now, what are the symptoms? See, it all depends upon the calcium levels, because hyperparathyroidism, how the patient will develop the symptoms. There are two reasons why the clinical features will be there in hyperparathyroidism. One is because of increase in calcium, and the second is due to excessive bone resorption, right? Because that excess calcium is coming from the bone itself, right? So this excess calcium, which is elevated, depending upon the levels of increase in calcium, you will have the clinical features of hyperparathyroidism. Okay. Now, if you take the normal calcium levels, that will be around 8.5 to 10.5 milligrams per deciliter. Now, if the individual have the calcium levels in between 11 to 13, right, or 11 to 12, then these individuals will develop the renal calculi. The kidney stone formation will be there, right? There will be nephrolithiasis, and there will be stimulation of the parietal cells, where there will be increase in HCl secretion, and there will be contraction of the sphincters of the GIT. That will result in constipation, right? Next, and if the calcium levels, if they are in between 13 to 15, this calcium will cross the blood-brain barrier, and calcium will accumulate in the brain, resulting in psychosis. And there will also be development of secondary Parkinsonism due to damage to the basal ganglia. That is what will happen when the calcium levels are in between 13 to 15. And when calcium levels are more than 15, then these patients will develop systolic arrest. Right? When calcium levels are more than 15, these patients will develop systolic arrest. Okay. Next. Now, apart from this, you will also have bony abnormalities. So what will be that bony abnormalities? There will be osteoporosis. And because of this osteoporosis, there will be pathological fracture in these patients. There will be pathological fracture in these patients. Okay. And apart from this, if you observe the skull of these individuals, right, the skull of these patients with hyperparathyroidism, when you do an X-ray, you will notice what is called as pinhead stippling. And when you take a dental film, there will be loss of lamina dura. Right? There will be loss of lamina dura. Now, what do you mean by this word lamina dura? it is the mineralized portion of the mandible. So in a hyperparathyroidism, there will be demineralization, right? Next. And if you take the spine of these individuals with primary hyperparathyroidism, spine if you take, you will notice what is called as codfish spine, right? Or we describe it as the rugged jersey spine, right? We describe it as the rugged jersey spine. And another important bony abnormality will be development of the pathological fracture. Okay, so these will be bony abnormalities in patients with the hyperparathyroidism, right? Now coming to the diagnosis, there will be elevated parathormone levels, right? And along with that, there will be also increase in calcium levels. So calcium levels are elevated. So when you do an ECG in these patients, what is that you will notice? You will notice that there is, or there will be a short QT interval, right? There will be short QT interval. And what is the purpose of doing this DEXA scan? The purpose of doing this DEXA scan, this will help you to make out the bone mineral density. And in this bone mineral density, like in DEXA scan, we measure two scores. One is T score, the other one is Z score. T score is that where the bone mineral density of the patient is measured with 30-year-old healthy individual. Right? The bone mineral density of the patient is compared with 30-year-old healthy individual bone scan. Whereas Z score is that where the bone mineral density of the patient is compared with the same age individuals but who is healthy. That is what is called T score and as well as Z score, right? And how much is the normal T score? Normal T score, it should be more than -1. And how much is the normal Z score? It should be more than -2. This will be the normal Z score. Okay, right. And so the DEXA scan will tell you whether the osteoporosis is there or not. Then followed by that, the SPECT or the CT scan. So the SPECT or CT scan will help in localization. And we have a scan called Technetium 99M System EV scan. Right? Technetium 99M System EV scan. So this Technetium 99M System EV scan, this will help us in localizing this tumor. So this is how you will work up for the patient with the hyperparathyroidism. Now, if you take the treatment of these patients, so if you see the treatment in primary hyperparathyroidism, the treatment of choice is the surgical excision. Right? The treatment of choice is surgical excision. Surgical excision is the definitive treatment. Right? And what is the approach that is being favored? Minimally invasive approaches are being favored. Minimally invasive approaches are being favored. Okay. And next important is the medical management. So medical management, what we do is, what exactly is the drug of choice? The drug of choice is bisphosphonate in case of primary hyperparathyroidism. What these bisphosphonates will do? Bisphosphonates will prevent the bone resorption. But at the same time, what is that you need to do? You need to reduce the serum calcium levels as well. You need to reduce the serum calcium levels as well. So how will you reduce the serum calcium levels? That is by IV fluids. And in the IV fluids, what is that you need to give? Normal saline should be given. In the IV fluids, what is that you need to give is normal saline should be given. Okay. And along with normal saline, these patients, okay. So along with normal saline, you need to give the furosemide. This will cause the flushing out of that excess calcium. That is the treatment in case of primary hyperparathyroidism. And at the same time, this calcitonin should be given. That will prevent the bone resorption, right? And vitamin D analogs. Vitamin D analogs are given in the cases of secondary hyperparathyroidism, not in case of primary. In secondary hyperparathyroidism, wherever there is vitamin D deficiency causing secondary hyperparathyroidism, there we give vitamin D analogs, right? And at the same time, once you have done parathyroid adenectomy, what can happen? There can be development of the hypocalcemia. So that is the reason why you need to monitor the calcium levels. Then the calcium and vitamin D supplementation should be given. Calcium and vitamin D supplementation has to be given. Okay. Then followed by that, the parenteral calcium. Then followed by that, the parenteral calcium. So parenteral calcium should be given if severe hypocalcemia occurs. right? Parenteral calcium should be given if severe hypocalcemia occurs, right? If severe hypocalcemia occurs, then the parenteral calcium should be given. And that parenteral calcium, that is in the form of the intravenous calcium gluconate. That should be in the form of intravenous calcium gluconate. And that too, 10% of the calcium gluconate should be given in 10 ml of the normal saline, right? And you need to correct hypomagnesemia if it is needed. Okay, so this is like the treatment in primary. After post-operative, what is the treatment? So same way is your parathyroid carcinoma also. Parathyroid carcinoma also, the surgical excision has to be done. But the very important point is you need to avoid the capsular rupture. You need to take care of the capsule and you need to avoid the capsular rupture. Right? And how is the recurrence managed? Recurrence is managed with surgery or the embolization. Recurrence is managed with surgery and embolization. So this is about the parathyroid carcinoma. Okay, so we are done with hyperparathyroidism, but let me tell you what are the recent trials, right? There are some new molecules and new treatment options as well. So what about doing parathyroid adenectomy in asymptomatic primary hyperparathyroidism? So there was a trial done and it's an RCT, randomized control trial, right? So where they have compared parathyroid adenectomy to observation in asymptomatic patients. So one group observation, one group they have done parathyroid adenectomy, right? Now, what was the conclusion of this RCT? The conclusion of the RCT was parathyroid adenectomy benefits bone health and it will improve the quality of the life in asymptomatic primary hyperparathyroidism. So this is one of the trial. So in case of asymptomatic primary hyperparathyroidism also, if you do parathyroid adenectomy, that has improved the quality of the life of the individual, right? Next, the another important molecule is the cinacalcet. Cinacalcet for the primary hyperparathyroidism management. So what is this? This is also an RCT, right? This is also the RCT, right? The randomized clinical trial. So what this study has concluded, whenever you give cinacalcet, which is a calcimimetic agent, that will normalize the serum calcium levels in primary hyperparathyroidism, right? This is a viable option in non-surgical treatment patients, right? So this is one of the option in non-surgical treatment patients. So the molecule is cinacalcet, right? Then one more important molecule, but this is for secondary hyperparathyroidism. And what is the name of this particular molecule? That is etelcalcetide, right? Etelcalcetide, right? So this is randomized, double-blind, placebo-controlled trial. So this is done in patients with chronic renal failure who are undergoing hemodialysis, right? Who are undergoing hemodialysis. What this particular drug showed, that is etelcalcetide, it has shown that this etelcalcetide is an effective treatment option for secondary hyperparathyroidism in hemodialysis patients. That was found about the etelcalcetide, right? So these are the new molecules. Okay, so parathyroid adenectomy should be done in case of asymptomatic patients, right? And in non-surgical patients or not fit for surgery, cinacalcet is one of the treatment option. Whereas in secondary hyperparathyroidism who are undergoing hemodialysis secondary to chronic renal failure, in them, one of the new molecule is the etelcalcetide. Okay, now we'll do some questions on the topic of hyperparathyroidism. Okay, right. You see this question? Yeah. Right. So we have right. So we have a 55-year-old woman with primary hyperparathyroidism. The patient is scheduled for surgery. Right. So what is the definitive management for the condition? Bisphosphonates, calcimimetics, then parathyroid adenectomy, then observation. Yeah, very good, Dr. Deepal. So in primary hyperparathyroidism, the treatment of choice is, the definitive treatment is parathyroid adenectomy, right? And this parathyroid adenectomy should be done especially in symptomatic patients. Right? It should be done especially in symptomatic patients. Right? And this is also the treatment in patients with significant hypercalcemia who are asymptomatic. And this is also the treatment in those individuals who are having osteoporosis secondary to hyperparathyroidism. Right? And even in those individuals who are having nephrolithiasis also, in them also you need to do the parathyroid adenectomy. Right? So this parathyroid adenectomy, if the treatment option is not available for the patient, then medical management should be given. And that medical management should be in the form of this bisphosphonates or calcium-mimetic agent cinacalcet. Right? Cinacalcet. Okay. Right. Yeah. Actually, if you take the the T-score, if you take, the normal value is actually more than minus 1.0. But if the T-score, if it is minus 1 to minus 2.5, this we call it as osteopenia. And when do you call osteoporosis? When the T-score is less than minus 2.5, then we call it as osteoporosis. When T-score is less than minus 2.5, we call it as osteoporosis. Okay. So that is when you need to do parathyroid adenectomy. All right. Done. So that was the first question. Now, you see the second one. A patient with asymptomatic hyperparathyroidism is being monitored. Which of the following is an indication for the surgical intervention? Which of the following is an indication for surgical intervention? Serum calcium 0.5 milligrams per deciliter above the normal bone mineral density, age less than 50 years, no kidney stones. Right. So, yeah. So here the correct answer is the age less than 50 years. Right. So, like, the surgery is indicated when the serum calcium is more than 1 milligram per deciliter. Right. The serum calcium is more than 1 milligram per deciliter above the normal. Or if there is osteoporosis, then you should do this parathyroid adenectomy. Right. Or if there is kidney stones, right, or if there is nephrolithiasis, that is a point when you need to do the parathyroid adenectomy. Right. So this is about like the second question. What is the indication for parathyroid adenectomy? Done. Next one. Okay. Right. So a patient with hyperparathyroidism and severe hypercalcemia requires immediate management. What is the first line treatment in these patients? What is the first line treatment in these patients? Right. So the first line treatment in this patient is you need to give intravenous normal saline. What this intravenous normal saline will give, this will give you a dilution effect. Right. So this will give you the dilution effect. Okay. And along with this intravenous normal saline, followed by that, you need to give loop diuretics. Right. That is furosemide. But the first line management is what? The intravenous normal saline is the first line management. Right. And this bisphosphonates, they are considered as drug of choice. And what is that particular drug? That is ibandronate. That is ibandronate. But the first line treatment will be intravenous normal saline should be given. Done. Next question. Right. Which of the following medication is a calcium mimetic agent used in the treatment of secondary hyperparathyroidism? Yeah, yes, Dr. Dipal, you're right. These individuals, they'll have polyuria. Okay, so Patients with hypercalcemia, they will be having the polyuria, right? So there will be dehydration, right? And so for that reason, we give normal saline first. Yeah. So which of the following is a calcium mimetic agent? That is the cinacalcet. Cinacalcet is a calcium mimetic agent that what this will do, this will reduce, right? So this will reduce the parathormone secretion by increasing the calcium receptor sensitivity, right? So it will reduce the parathormone secretion by increasing the calcium receptor sensitivity on parathyroid gland, right? So that is the reason why it is very much effective in case of secondary hyperparathyroidism in chronic renal failure. Whereas you take this alendronate, it is used in the treatment of the osteoporosis, right? Used in the treatment of the osteoporosis. Okay. And even reloxifene is also used in the treatment of the osteoporosis. Whereas teriparatide, it is parathormone analog. It is a parathormone analog. Where do we give this teriparatide? We give teriparatide in cases of the acute hypoparathyroidism. In acute hypoparathyroidism, we give this teriparatide. Okay. What are the causes for acute hypoparathyroidism? That is thyroid surgery. That is one of the etiology for acute hypoparathyroidism. There we give teriparatide. Okay. Next question. A 60-year-old man undergoes successful parathyroid adenectomy for primary hyperparathyroidism. What is that should be monitored post-operatively? Right. So the serum calcium has to be monitored, right? There will be development of hypocalcemia. Now the question is, once you've done a parathyroid adenectomy, why there is hypocalcemia? See, this hypocalcemia can occur post-operatively, and this is due to hungry bone syndrome. Right? So this is due to hungry bone syndrome. So due to hungry bone syndrome, and what exactly is this hungry bone syndrome? Where bones rapidly absorb the calcium after the removal of the overactive parathyroid gland. So that is the reason why close monitoring of the serum calcium and supplementation is needed, and it is very much essential as well. Okay, so this is about the hyperparathyroidism. Done. Now, after having discussed about the hyperparathyroidism, we'll move on to the discussion of the hypoparathyroidism. Now, what are the etiologies for the hypoparathyroidism? We have genetic causes for hypoparathyroidism, right? Then inherited causes for the hypoparathyroidism. And we also have mutations causing hypoparathyroidism. All that let me try to discuss. Okay. Now, this genetic causes for hypoparathyroidism, if you observe, it is associated with abnormalities such as Digeot syndrome, HDR syndrome, then Kenne-Caffey syndrome. These are the genetic causes which are responsible for the hereditary hypoparathyroidism, and it can be isolated. Right? So isolated hereditary hypoparathyroidism. Now, whereas you take in case of Digeot syndrome, right? So in Digeot syndrome, a gene is being mutated, right? And where is this particular gene present? This particular gene, it is present on the chromosome number 21, right? So what all will be the abnormalities in case of the Digeot syndrome? In case of Digeot syndrome, first and foremost, there will be a defective thymus abnormality. There is defective thymus gland. And because of defective thymus gland, these individuals, they are more prone for infections. Right? They are more prone for infections. Then there is also defective parathyroid development resulting in hypoparathyroidism. And there is also congenital cardiovascular and facial defects. And these facial defects will be in the form of cleft palate. Right? So this will be Digeot syndrome. Then what are the other gene mutations? That includes GATA3, TBC, AIRE mutation, mitochondrial genes like KSS, MELAS, and GCM2, they contribute to hereditary hypoparathyroidism. Right? They contribute to hereditary hypoparathyroidism. Then we also have isolated hypoparathyroidism. And this isolated hypoparathyroidism can be anything, either autosomal dominant or autosomal recessive or X-linked. Right? And mutations in parathyroid hormone and CASR genes, they will lead to the functional defects. So these are all the various etiologies that will be responsible for hypoparathyroidism. Now, whatever we have discussed here is genetic causes, right? They are mainly due to gene mutations. DIGER syndrome, HDR syndrome, Kenny-Caffey syndrome, right? GATA3 mutation, TBCE mutation, AIRE mutation, right? And these mutations, they are being inherited as either autosomal dominant, recessive, or X-linked. Apart from this, we also have acquired hypoparathyroidism as well, right? Acquired hypoparathyroidism as well. So this acquired hypoparathyroidism is usually post-surgical. There is a large goiter of thyroid gland and you have done thyroidectomy. That will result in the hypoparathyroidism. Right. So I'm sorry. So just 1 minute. Yeah. So acquired hypoparathyroidism, it is usually post-surgical, or it can be radiation induced. Like there is cervical lymphoma and you are giving the radiation therapy for cervical lymphoma. And that radiation has hit the parathyroid gland causing hypoparathyroidism, right? Or it could be due to glandular damage also, like hemochromatosis, hemosiderosis, or due to infection as well. What will be the clinical symptomatology in these patients? See, basically, the clinical features are mainly due to hypocalcemia, right? So there will be neuromuscular manifestations. So there will be muscle spasm, there will be carpopedal spasm resulting in tetany, right? And the cause of death in these patients, is due to laryngospasm. And these patients also will develop convulsions. And there is also raised intracranial pressure. And due to hypocalcemia, they will have long QT interval. See, in hypercalcemia, you'll have short QT interval, whereas hypocalcemia, you'll have long QT interval. And there are multiple electrolyte abnormalities where you have long QT interval. Long QT interval is also observed in patients with hypokalemia. Long QT interval is also observed in patients with hypomagnesemia as well, right? And what are the gastrointestinal manifestations of hypocalcemia? So that will be intestinal cramps and as well as like a chronic malabsorption. And due to hypocalcemia, there are two important signs. One is Chostek sign and the other one is Trojer's sign. What is Chostek sign? You tap the facial nerve over the angle of the mandible, you will have the spasm of the muscles on that half of the face. Then what is this Trojer's sign? You apply the BP cuff and you inflate the BP cuff in between systolic and diastolic blood pressure and you leave it for 2 to 3 minutes. You will notice that there is a carpopedal spasm. That is what is your Trojer's sign. But you should not again confuse with the Trojer's lymph node. Trojer's lymph node is left supraclavicular lymph node, which is also called Virchow's lymph node, which is seen in carcinoma of the stomach. And at the same time, you should not get confused with the Trojer's sign of malignancy. Trojer's sign of malignancy is a migratory thrombophlebitis seen in case of pancreatic carcinoma. So we come across this term Trojer's at 3 places: hypoparathyroidism, carcinoma of the stomach, and the other one is the pancreatic malignancies. Now, how do you treat these and how do you work up these patients? Workup is very simple. The calcium levels are reduced, right? And the phosphate levels will be elevated, right? Then the ECG will show you long QT interval and parathormone levels will be reduced. And very important is you need to know about the alkaline phosphatase levels. So if you take the alkaline phosphatase levels, they are normal in patients with the hypoparathyroidism, but the alkaline phosphatase levels, they are elevated in patients with the primary hyperparathyroidism. In primary hyperparathyroidism, the alkaline phosphatase levels are being elevated. Whereas in hypoparathyroidism, the alkaline phosphatase levels, they remain normal, right? Next. Now coming to the treatment in patients with the hypoparathyroidism. So in hypoparathyroidism, what is the problem? There is hypocalcemia. So how do you manage those patients? You need to give vitamin D and as well as the calcitriol injections, high dose vitamin D or calcitriol injections. And along with that, the oral calcium intake is also required. And the treatment is different in acute and chronic. In cases of acute hypoparathyroidism, what are the causes for acute hypoparathyroidism? that is parathyroid surgery. Thyroidectomy. So in acute hypoparathyroidism, you need to give intravenous calcium gluconate, and along with that, you need to give teriparatide. Whereas in case of chronic hypoparathyroidism, we give oral vitamin D, oral calcium supplementation should be given, right? And the other thing is these thiazide diuretics. What is the role of thiazide diuretics? Thiazide diuretics, they reduce the urine calcium excretion, thereby preventing hypercalciuria and easing the management of the individual. And the next is the synthetic parathormone. Synthetic parathormone, right? So this synthetic parathormone, it is approved for hypoparathyroidism therapy because it improves the calcium homeostasis. And at the same time, hypomagnesemia is one of the cause for hypoparathyroidism. Why? Because magnesium is required for parathormone release from parathyroid gland. Right? Magnesium is required for parathormone release from parathyroid gland. And if magnesium is not there, that will result in hypoparathyroidism. So if there is severe hypomagnesemia, when the magnesium levels are less than 0.4 millimoles per liter, that will lead to hypocalcemia by impairing parathyroid hormone secretion. By impairing parathyroid hormone secretion. And these patients, they will be requiring parenteral magnesium repletion. These patients require parenteral magnesium repletion. Okay. Next is chronic kidney disease. So chronic kidney disease patients, they will not be having hypoparathyroidism, but what is that they'll be having is secondary hyperparathyroidism is what they'll be having. And how do you treat these CKD patients? Like you need to do the phosphate restriction, or you need to give phosphate binders. But that phosphate binder should be given after, right? Or these, so first you should give phosphate binders, then followed by that only you need to give calcium supplementation. What are those phosphate binders in case of chronic kidney disease? Right? That is the aluminium hydroxide, calcium acetate. Okay, so these are the phosphate binders. Then, yeah, so this is about the treatment of CKD, and in CKD patients, you also need to give calcitriol. This is about hypoparathyroidism. And we have one more form of hypoparathyroidism called pseudo-hypoparathyroidism. And in case of pseudo-hypoparathyroidism, here parathyroid hormone receptors, they are resistant. Right? Parathyroid hormone receptors are resistant. And why is that? This is due to gene mutation. And what is the gene mutated? That is, the GNAS gene is being mutated. That is what is the gene mutated. And these patients with pseudo-hypoparathyroidism, the parathormone levels, they may be normal, or in fact, they may be increased also due to hypocalcemia. So the treatment that you need to give in patients with pseudo-hypoparathyroidism is you need to give calcium supplementation, because parathormone is not able to act on parathormone receptors. Right? Now, let me discuss what are the recent trials on the hypoparathyroidism treatment. So in hypoparathyroidism treatment, we have the phase 3 trial, right? And it is also randomized, double-blind, placebo-controlled trial, where this particular trial have introduced a molecule that is transcorn parathyroid hormone. And the name of the molecule is palopig teriparatide, right? Palopig teriparatide. Okay. So this palopig teriparatide, this effectively maintains the serum calcium, and that will reducing the need for conventional therapy. So this is one of the new molecule, right? That is palopig teriparatide. Okay. That is one molecule. And the other important trial, that is also a phase 3 trial, right? And that is investigating therapeutic peptide. And what is that molecule? That particular molecule is eniboparatide, right? Eniboparatide. So this is another potential molecule in managing hypoparathyroidism by stabilizing the calcium levels, right? By stabilizing calcium levels, right? So one important molecule was palopig teriparatide. The second molecule is eniboparatide, and next is encalirate. Encalirate, but this is in phase 2 trial. And in which group of individual this is beneficial? This encalirate, it is beneficial for ADH1 patients by addressing the underlying molecular defects. right? So those individuals with ADH1 mutation, in them, this N-calirate is required, right? So what is ADH1? Autosomal dominant hypocalcemia type 1. That is called ADH1, right? Next important molecule is teriparatide. So this teriparatide, it is for post-surgical hypoparathyroidism. That's what I said. I have discussed. Those individuals who have undergone goiter resection, they will be developing acute hypoparathyroidism. So in them, you need to give teriparatide. And this teriparatide may aid in the recovery of parathyroid hormone following the surgery. So this is about the treatment. So these are the new molecules. One is palopec teriparatide. The other one is eniboparatide. Next is the N-calirate, that is for autosomal dominant hypocalcemia type 1. And next important molecule is the teriparatide. That is for post-surgical hypoparathyroidism. Okay. Now, let me discuss some of the questions on the topic of hypoparathyroidism. Yeah. So you see the next question. So we have, right. Yeah, 1 second. I'm just sorry for this gene mutation. Catch 22. I'm sorry. Right. So catch 22. I'm very sorry for that. Right. So a 45-year-old woman with post-surgical hypoparathyroidism presents with tetany. What is the immediate management that has to be given in post-surgical hypoparathyroidism? Oral calcium, IV magnesium, IV calcium gluconate, then calcitonin. Yes. So post-surgical hypoparathyroidism, the immediate management is intravenous calcium gluconate has to be given, because the individual will end up in acute case of or acute form of hypoparathyroidism. And if you don't give, so this 10% calcium gluconate has to be given, 10 ml of the normal saline, right? So that will prevent the development of the arrhythmias. Otherwise, if there is hypocalcemia, the individual will go into a state of the arrhythmias, right? Prolonged QT interval will be there, and there can be development of Torsades D pointers. Next. So a patient with chronic hypoparathyroidism, he is on calcium and vitamin D therapy, right? But he develops nephrocalcinosis, right? Patient with the chronic hypoparathyroidism is on calcium and vitamin D therapy, but develops nephrocalcinosis. What should be added to the treatment? What should be added to the treatment? Yeah, Lokesh, thank you very much. Yes, Alina, you're right. Thank you, Dr. Alina. So the correct answer is the thiazide diuretics. Why are we giving thiazide diuretics? Thiazide diuretics, they reduce the urinary calcium excretion. Right? They reduce the urinary calcium excretion. Right? And they help in preventing the nephrocalcinosis. Whereas what these loop diuretics will do, loop diuretics increases the calcium excretion. Right? Loop diuretics, they increase the calcium excretion. So thereby they may worsen the condition. So that is the reason why the preferred molecule is the thiazide diuretics. Right? Next. Yeah. Which of the following is FDA approved recombinant parathyroid hormone analog for hypoparathyroidism treatment? What is the recombinant FDA approved recombinant? Yeah. So the molecule is the teriparatide. So this teriparatide, it is parathyroid hormone 1 to 34, and it is approved recombinant parathyroid hormone analog, which is used in the treatment of the hypoparathyroidism, and it is also used in the treatment of the osteoporosis. Right? Also used in the treatment of osteoporosis. Right? And what this teriparatide will do? This teriparatide will stimulate the bone formation. Right? So this will stimulate the bone formation, and thereby it helps in maintaining the calcium balance. Thereby it helps in maintaining the calcium balance. Okay, right. Next. Yeah, which of the following is true regarding magnesium in the management of the hypoparathyroidism? Hypomagnesemia does not affect parathormone secretion. Magnesium deficiency can cause functional hypoparathyroidism. Magnesium supplementation is contraindicated. Magnesium levels are irrelevant in calcium regulation. Right. Good, Dr. Alina. So, magnesium deficiency, this can cause functional hypoparathyroidism. So that is the reason why these patients with the hypoparathyroidism, you need to monitor the magnesium levels. If there is hypomagnesemia, you need to correct the magnesium levels. Okay, right. So magnesium correction, it is very much essential before the calcium levels can normalize. Last question. Okay, so a patient with hypoparathyroidism, right? He is maintained on vitamin D and calcium. He is maintained on vitamin D and calcium, but develops the hypercalciuria. What is the next step in the management of the patient? What is the next step in the management of this patient? Right. So this patient is having hypercalciuria. This patient is having hypercalciuria. Just 1 second. Right. So in order to ensure that the calcium excretion through the kidney is being reduced, so what is that you need to do? You need to start a thiazide diuretic. You need to start a thiazide diuretic. Okay. 1 minute. Okay. So this is about the parathyroid related disorders, both hypo and as well as hyperparathyroidism. Now, so if you take this, yeah. Yeah, adynamic bone disease. Okay, let me explain you about this adynamic bone disease. Now, so I'll take the other slide. So if you take this adynamic bone disease, this is one of the metabolic bone disorder which is characterized by, right, there will be low bone turnover. Right, so these patients, they'll have low bone turnover. And why is that there is low bone turnover in patients with adynamic bone disease? This is due to suppressed osteoblastic, right? This is due to suppressed osteoblastic and due to suppressed osteoclastic activity. So both of these cellular activity is reduced. That is what is responsible for the low bone turnover in these patients, right? And this adynamic bone disease, this is a subtype of renal osteodystrophy, right? So this is a subtype of renal osteodystrophy, right? And this is commonly seen in patients with CKD who are undergoing hemodialysis, right? Who are undergoing hemodialysis. So what are the causes for this adynamic bone disease? That is due to, so the etiology will be, the causes will be over suppression, right? Over suppression of the parathyroid hormone. This will be the cause, or the other causes will be CKD and or CKD mineral bone disease, right? CKD mineral bone disease, or even it could be because of the aluminum toxicity also. These are the causes for adynamic bone disease, right? And what is the pathophysiology is, see, it is mainly because of the over suppression of the parathyroid hormone levels. So parathormone levels, when they are suppressed, there is suppression of bone remodeling, right? There is suppression of bone remodeling, right? There is suppression of bone remodeling. So there is decreased osteoblastic and there is also decreased osteoclastic activity as well. In case of this adynamic bone disease, that is due to low parathormone levels. Now, because there is decreased or low bone turnover, What will be the clinical features in these patients? They are at increased risk of pathological fractures, right? Especially the hip and vertebra. Pathological fractures at the hip and as well as the vertebra. And these patients, they will also present with bone pain. And they will also have the muscle weakness, right? And these patients with adynamic bone disease, they are at increased risk of the cardiovascular disease risk, right? They are at increased risk of the cardiovascular abnormality. And how will you diagnose this adynamic bone disease? So diagnosis of adynamic bone disease is that there will be low or inappropriately normal parathormone levels. Either they may be low or normal parathormone levels, right? And what is the gold standard diagnosis? Gold standard diagnosis will be bone biopsy. Bone biopsy is the one which will show you that there is low osteoblastic and low osteoclastic activity, right? And how do you treat these patients? So these patients are at increased risk of pathological fracture because of low bone turnover. So you need to adjust the calcium and as well as the vitamin D. And you need to modify the phosphate binders, right? And examples of the phosphate binders are sevelamer hydrochloride, lanthanum carbonate, aluminium hydroxide, calcium acetate. And if parathormone levels are too low, then parathormone modulation should be given, right? Parathormone modulation should be given. And you should avoid giving bisphosphonates, right? Avoid giving bisphosphonates. Okay. So this is what is the adynamic bone disease. This is what is your adynamic bone disease. Okay. So basically the problem here is that there will be low bone turnover and there is increased osteoclastic and there is also increased osteoblastic activity, right? Yeah. Can we give teriparatide, right? What is this teriparatide? It is a parathormone analog, right? Yes. So when parathormone levels are too low, then you can give teriparatide. If parathormone levels are too low, then you can give teriparatide. Okay. So this is about the adynamic bone disease, right? So with this, I'll wind up this particular section, right? And if you have any doubts, if you have any doubts, you can just ping me on my Instagram. You can DM me, and my Instagram ID will be the Rajesh Gubba, right? So any doubts you have, you can just ping me. So definitely I'll answer you back, right? So thank you very much, and I wish you all the best for your upcoming exam.